Good afternoon. I'd like to welcome you all to the 101st meeting of the American Association of Plastic Surgeons. Here back in the city of Chicago, where it all started, where the initial meeting took place, it's my pleasure to welcome you all here for what promises to be an outstanding meeting. I have often thought, and I particularly thought this during the new members' luncheon this afternoon, what makes the association so special? One answer: the people who are part of it. And there's no question about it. In my career, I've had just an outstanding time, both in plastic surgery, but also with the individuals I've had the pleasure of working with. And perhaps that nothing exceeds that more than my colleagues who I selected to be chairs of the program committee. Dr. Frank Pepe from the Cleveland Clinic and Dr. Jack Yu from the Medical College of Georgia. Gentlemen.
Well, thank you, Bob, and welcome everybody to the next century of the American Association of Plastic Surgeons. It's been an honor to really assist with you, Bob, and Jack. It's been a lot of fun. And I can't think of any other surgical subspecialty where innovation is the most important. It's the most important for plastic surgery because we're the fix-it people, right? From the top of your head to the bottom of your feet. And to really create this meeting together, we had to have an immense program committee. And I'd like the people that were on the program committee to stand up to recognize. Please stand up. There was two. Now, if you saw on page 6, there's probably over 50 or 60 people. So, we've had over 700 abstracts that were submitted, over 700. Jack's going to go over the stats behind that. He does that much better than I do. And besides that, I think we have the second largest attendance in the history of the association, and that's really an exemplary reason of why innovation is so important. So I'm going to go hand it over to Jack, and Jack's going to talk about all the stats.
Thank you, Frank. Thank you, Bob. It's been an absolute pleasure to work with these two over the past several months, and with the members of the program committee. As you can see, there are more than 740 papers submitted, and out of those, 714 were extracted out, and one withdrawal, and so it's total 713, and out of those, we selected about 124. The total acceptance rate is about 17%. Out of those accepted, 61 were for the podium presentation, given a cutoff about 8th percentile. So these are very, very high quality papers, and I congratulate all of them. And this year, a little different is that we select the top 10. The best abstract of each group of the submitted to the best meetings will be recognized. They're identified in your book as with a star. And I also would like to ask the moderators to identify the top 10. They are really, really good abstracts, and if you look at their distribution, the standard deviation is exactly 1/3 of the mean, so they're very, very tight and very, very true to the normal distribution. Finally, please silence your phone during the session and stay on time. The moderator will enforce. For the discussant, the question should be to the point, and for the answers, please answer to the question. You will thoroughly enjoyed this year's noon lecture. It's a special treat. Her name is Lindsay Fitzharris. She's a PhD from Oxford, and she will talk about how plastic surgery was born. We should all be very proud of being plastic surgeons. So without further ado, please enjoy the meeting, and I look forward to the sessions. Thank you very much.
I'd now like to welcome the Secretary of the Association, Dr. Joe Cerletti. Joe.
Thank you. I'm sure everyone here realizes the best job of being secretary is to introduce the new members. So before I do that, Shayla wanted me to remind everybody here about the change in the application process, so that in 2001, we changed things so that people can be nominated this coming year. We will vote on them later in the year electronically, and then they get inducted at next year's meeting. So the time to new membership is basically a year. And so this group that we're inducting today, they went through that same process. So if you have people that you want to put up, please do that. We're accepting applications from people who were boarded 2017 and older. So if you have young faculty and they were boarded in 2017, they're eligible for election to membership this coming year. All right, so you guys, I'm going to call you one by one, and if you can just get up, and isn't that what you want to do, right, Bob? Yeah, and just start over there and just make a line. So we had a lunch, and they all got their certificates. So this is just for all of you to meet and recognize them. Alexander Alori, Michael Alperovich, Dunya Atisha, Albert Chow, Carrie Chu, Gabriel Del Corral, Christopher Doherty, Richard Ehrlichman, Karen Evans, John Felder, Harold Friedman, Michael Friel, Analio Garcia, Brian Glatt, Christian Kaufman, Esther Kim, Peter Koltz, Anand Kumar, Jeffrey Larson, Joseph Napoli, Feng Wen, Dong Wen, Andre Odobescu, Nicholas Panetta, Edward Reese, Dhruv Singhal, Ahmed Suleiman, Wesley Thayer, Ali Totanchi, Ian Valerio, and Carrie Woodbury. So please join me in welcoming these new members of the association.
Thank you, Joe. Appreciate that. And congratulations to the new members of the Association of Plastic Surgeons. Appreciate it. Congratulations, folks. Next, I would like to welcome a vital part of our association, Dr. David Larson and Dr. Mark Constantian, to speak about the Canon Medical Student Program. Dr. Larson, Dr. Constantian.
Thank you, Dr. Havlik. Well, first and foremost, I am grateful to be standing here with my good friend and colleague, Mark Constantian, as we are introducing the 6th year of the Cannon Scholarship Program, which is for medical students, and it has become so popular over these last few years that we had to limit the applications to only second and third year medical students. And even then, we had almost 200 applicants. It is, and what happened, the way it works is you as members and us as Canon members will present, will donate $500. That $500 will support one student and pay for their registration, all the meals associated with the meeting, and 2 nights in the hospital. 2 nights in. You can tell I'm a doctor. Two nights in the hotel, and I guess if they have to go to the hospital, that'd be covered too. So, so with that in mind, and the people, the members who donate their $500, which by the way is tax deductible, they are privileged to be able to rank the members, these scholarships, the applications, and it's the ranking of them that determines the 27 students that we're about to introduce. So Mark and his wife Charlotte have been instrumental in supporting this effort, and I'll let him talk about that in just a second. But right now, we're just going to introduce the students, and we'll each read their names, and hopefully they'll be correct. And what the other thing is, I would ask each of them to stand as their name is called, but hold any applause until after they're all standing. Mark? Okay, I guess I'm first. Jad Abi Rafay.
Joshua Cohen,
Maheen Akir.
Sabrina Lazar,
Ashira Anderson.
Marina Lenkevich,
Alatunde Bashuram.
Stephen Mura,
Natalie Baxter.
Jingang Jenny Ng,
Michelle Benedict.
Alvin Nguyen,
Kasavia Buckley.
Praneet Paidaseti,
Annie Chen Carrington.
Jasmine Panton,
Sarit Dahar.
Isabel Scharf,
Theodore Hackbarth.
Darshan Savara,
Eva Hale.
Joshua Weissman,
Chandler Hinson.
Megan Wu,
Sharon Kim.
and Samantha Zahn Moody.
Welcome to you. They're all wearing little name tags that have Canon student. As a member, reach out to them, introduce yourself, so that they can really get a feel for the fellowship and the camaraderie that we are also familiar with, associated with this organization. And these men and women, I want to go to the next slide. Oh, nope, go back. I wanted to go back one more. There we go. I wanted to recognize, and I neglected to do this earlier, I'm sorry, the donors. These are those men and women who have donated this year to support these students. And I might say that the students are there's 27 students from 23 different institutions. About 6 of those institutions don't even have a plastic surgery program in their medical school. But they were so interested in plastic surgery that they made an application, and of course, were accepted. So again, thank you very much, and you may be seated. Mark?
To talk a minute about the donor fund, the original concept of this Canon Student Fund was that we would reach down into medical schools and tell medical students something about plastic surgery and see if we could interest them in plastic surgery. That's not at all the demographic we found. The applicants already knew about plastic surgery. Many of them had been researching plastic surgery. Many of them had written papers. Some had NIH grants. It was the most impressive group. And the first year, we had no limitations. We got 50, the next year 75, the next year 150, then 250. So we had to put some restrictions. This year, we limited it to the first 75 applicants, and then we went through and ranked them. But this, looking through their CVs is like looking through the oral board cases. You can't race through it because they're all so deep. And so last year, or 2 years ago, I proposed, when I was on the board, I proposed to the board, and they accepted the idea that we, Charlotte and I, could capitalize a Canon Student Fund that we hope will grow and grow and eventually be self-perpetuating and fund a lot of the students, so it's not a yearly fund drive. So there are two ways you can contribute to bringing the Canon students here. One is each year when Dr. Larson sends out his appeal through the website. You can also go to the website and select the Canon Student Fund and donate to that as well, which is a corpus that we hope will grow. That, I think, formalizes the program. It raises its profile. We all feel really built further and enriched by this group and by this society. And I think if you go and make an effort, like Dr. Larson said, to talk to these medical students, you will realize the caliber of the people we're bringing it. They are very exciting and very enthusiastic and very bright. And hopefully, in the future, we'll be able to bring all 75, not just the first 28. I hope you'll consider donations to both groups.
Then mention your fund donor.
The fund donors for this year: Steve Arian, Mimis Cohen, Charlotte and me, of course, Bill Hoffman, Paul Schnurr, and Erica Sears.
So, again, thank you very much.
David and Mark, thank you so much. A very exciting development within the Association of Plastic Surgeons. Next, I'd like to introduce Dr. Aaron Green, who's chair of the Scientific Program Awards Committee, to introduce the AAP Resident Travel Award. Dr. Green.
Great, thank you. I wanted to thank this year's Scientific Programs Awards Committee for all of their hard work, not only choosing the AAPS Resident Travel Award, but also determining this year's Poster Award winner, the Rubin Award winner for this year, as well as the Young Clinician Researcher Award winner for this year. We had 18 amazing resident applicants for the Travel Award this year. There was actually a tie, a four-way tie for first place, and so we had to do another voting session. And so this year's winner is David Chi. He received a $1,500 scholarship to attend this year's meeting. David, are you here? Okay, maybe he's not here yet. So congratulations, David.
Thank you, Aaron. Next, it's my great pleasure to introduce the Vice President of the American Association of Plastic Surgeons, Dr. Arun Gosain. Arun.
One of the roles of the Vice President is to select what we feel is the best paper published by a plastic surgeon, and that's the James Barrett Brown Award. We have as our committee, looked through all of the papers submitted, not just to plastic and reconstructive surgery, but all journals. We had 13 member-nominated submissions, and we looked also at the most heavily clicked on, or the most heavily viewed online editions of PRS, and so we had another 15 of those, and this is the awards committee that made these decisions. And we came up with our James Barrett Brown Award, which, should we go ahead and, which is established in the memory of James Barrett Brown, who's the past president of the association, presented annually for this paper that we have mentioned. And the winner this year is David Chang for his paper, Physical and Functional Outcomes of Simultaneous Vascularized Lymph Node Transplant and Lymphovenous Bypass in the Treatment of Lymphedema. David?
Thank you very much. On behalf of my co-authors, Drs. Garza and Biederman, we would like to thank the association for this great honor. We would also like to thank our fellows who maintained this prospective database, which the studies was based on. Our disclosure. So lymphedema occurs when there's a failure of the lymphatic system, and over 250 million are affected worldwide. Over the past decade, there have been many publications that support the efficacy of these procedures to help reduce lymphedema, lymphovenous bypass, and lymph node transplant. Lymph node transplant works by lymphoangiogenesis. Patients may experience the effect months later. Lymphovenous bypass works by diverting the lymphatic fluid, and patients may experience the result almost immediately. With the idea that these procedures might be complementary, the senior author of this paper started to offer simultaneous lymph node transplant and lymphovenous bypass starting in 2013. Lymphovenous bypass is performed using endosanguine lymphography images, and lymph node transplant are performed either from lateral thoracic lymph nodes, inguinal lymph nodes, or supraclavicular lymph nodes, depending on the situation. The study included patients from October 2013 to February of 2019, both primary and secondary lymphedema involving upper and lower extremities. After the surgery, patients are instructed to perform compression wrapping for a total of 4 weeks. But after that, they resume their regular lymphedema therapy as needed. No strict lymphedema therapy regimen was used. Mean body mass index was 27. Average duration of lymphedema was 95.4 months. Upper extremity was involved in 57%, 43% lower extremity, 86% was secondary lymphedema, and 14% primary. Limb volume calculations were all performed by our University of Chicago lymphedema therapist using porometer. Pre- and post-operative lymphedema life impact scores were collected for each patient during all visits, as well as subjective improvement. Statistical analysis was performed as shown. Median baseline pre-op volume difference between the affected and unaffected limb was 25.7%. Patients experienced an average of 36.2% volume reduction at 2 years, and our data shows this is maintained at years 3 and 4. There was greater reduction shown for upper extremity compared to lower extremity, greater reduction in secondary versus primary lymphedema. Median lymphedema life impact scale scores improved at all follow-up time points. At 3 years, 27.5 points improvement was noted. Greater improvement was noted for upper extremity compared to lower extremity. No significant difference between secondary versus primary. 88% reported improvement in their lymphedema symptoms. 12% reported no improvement or worsening. Just an example, 73% larger left limb compared to right. Lymph node transplant to axilla, 2 lymphovenous bypasses, 3-year follow-up, 37% reduction in excess volume. So in conclusion, simultaneous vascularized lymph node transplant and lymphovenous bypass is an appropriate and effective approach for both early and advanced stages of primary and secondary lymphedema, with significant objective and subjective improvements. Volume reduction in the affected limb was observed at all time points postoperatively, with significant improvement in lymphedema life impact scale scores. Thank you very much.
Just absolutely wonderful work, Dr. Chang. Really one of the luminary papers in a field that's been challenging for so many years for plastic surgery and for patients. So thank you so much for that outstanding contribution. Next, I'd like to welcome William Austin for awarding the John D. Constable International Traveling Award.
Thank you very much. I'd like to also thank our committee for their hard work and really challenging task of picking one out of a very, very deserving group of possible traveling fellows. Dr. Constable really was an early believer that plastic surgery is really one global fellowship. He taught many of us that teaching, particularly internationally, is a privilege and a duty. And as many of you all know well, there are really no borders amongst plastic surgeons. This award is awarded to an international plastic surgeon funded by the association, and they travel the U.S. and train with our members. Past awardees are from 14 different countries. We've had 17 awardees, and it has been generally considered a real highlight of their career at that time. I'm very, very pleased to announce that this year's Constable International Traveling Fellowship Award winner will be Margaret Antai from Nigeria, University of Uyo Teaching Hospital. There were a number of really extraordinary applicants, but I'm really looking forward to meeting this one. She is only one of 2 plastic surgeons in her state. She performs pediatric and adult reconstructive surgery. She convinced her university to start a burn unit, which she founded, and I was really amazed to learn that in her area, a very poor area of Nigeria, it's not uncommon that kids with disabilities are accused of witchcraft and burned with petroleum jelly. So it's really an epidemic problem that she will be traveling around and looking to you for help improving these outcomes. So this fellowship is part of Dr. Constable's legacy and ours. He gave to this in his lifetime and in his will. And it really demonstrates what we believe and who we are. And it certainly needs ongoing fellowship support. Many have contributed, and really appreciate any further contributions. Also, really grateful for those of you who have hosted these fellows. It really means a great deal. The money that we give is important, but they really need help when they're here, and they have all expressed their gratitude, so thank you all.
Thank you so very much. The Clinician of the Year is an award that is presented by the President based upon a career of contribution to plastic surgery. It is representative of some of the most outstanding contributions over a lifetime. And this particular individual certainly fits that mold. He completed his surgery and plastic surgery residency at the Massachusetts General Hospital in Boston. He was a research fellow in surgical immunology at Harvard University. He then completed a fellowship in craniomaxillofacial and pediatric craniomaxillofacial surgery and pediatrics at the University of Pennsylvania Medical Center and Children's Hospital of Philadelphia, where he has been a faculty and attending since that time over the past many years. For many years, he traveled to Poland in a volunteer capacity, where he performed surgery and also trained Polish physicians in methods of facial reconstruction for children and adults. In 2004, he received the Mary Downs Endowed Chair in Pediatric Craniofacial Treatment and Research. In 2015, he received the American Society of Maxillofacial Surgeons President's Honorary Award. He's been a member of the American Association of Plastic Surgeons for 30 years. He's made multiple contributions to the literature for craniofacial surgery and plastic surgery. In addition, he has served as one of the most potent training centers in the United States for craniofacial surgeons. It's my pleasure to introduce the 2023 Clinician of the Year, Dr. Scott Bartlett. Scott.
I guess when Bob first called me about this, I said, geez, I think he must have the wrong person. But then when I looked back and thought about it, I said, you know, I'm only in this position because I've been very, very fortunate. And I wanted to just mention that at the outset, that time doesn't permit me to thank all the people who've contributed to my career. But I've been fortunate. I grew up in Utah, and at the time it was the Wild West. Plenty of skiing, plenty of hunting, plenty of fishing, and I could run wild. This is me with my family. I had a stable family, a brother and a sister, and I was always out catching animals. And the one person that figured most substantially in my life, in my early life, was my grandfather. His father had worked for the Union Pacific Railroad, and he could get a free train pass as far east as Chicago. So he got on the train and headed to Chicago and matriculated at the University of Chicago, graduating in 1910. And this letter was sent to him from Ogden, Utah. You can look at the date, June 21st, 1907. And it's notable for a couple of things. First of all, the address, Monroe Avenue. This hotel that we're in right now is on Monroe Avenue, which means 116 years ago, my grandfather was walking these very streets. Other thing that's notable, it's got a 1-cent stamp on it, and I don't think anybody in this room's ever seen a 1-cent stamp. He went on to graduate from Rush Medical College and the University of Chicago in 1912, and came back to Utah to practice medicine. And I used to spend hours talking with him about his experience. He was a general practitioner in Utah his entire life. And he was conscripted into the Army in 1918 and was sent to Fort Riley, Kansas as a pathologist, where he had some experience. And if anybody has not read this book, they should. It's The Great Influenza by John Barry. My grandfather was at Fort Riley in the military when the influenza, the Spanish flu, broke out. And if you read on the right there, the winter of 1918, the coldest the American Midwest had ever endured, was when a virus jumped from an animal to a human in Kansas, and then into the soldier population that was shipped overseas, and hence the beginning of the deadliest pandemic we've ever seen. And this is a picture from that book, and as I had mentioned, who would have known that some 100 years later that we would ourselves experience the same thing. So after that, I was fortunate enough to go to St. Louis and matriculate in Washington University. And it was really a great, great place, a great institution. And it's interesting when I look back, you know, we actually had to attend classes and lectures and labs. There were actually grades. Senior level medical students could function as interns and residents. Everybody worked many hours. And we actually had to take coursework through our entire senior year to graduate, far different than the medical students of today. But really for me, what was the defining part of my career was when I went to the Massachusetts General Hospital and spent 9 years there. And it really was a band of brothers. It was Jay's father, Jay Austin, who was just up on the podium, who was the leader of that band. And it was the only pathway to plastic surgery. You're on call every other night for 4.5 or 5 years. There were 2 vibrant board services. The ICUs were run entirely by the surgical residents. No PAs, no NPs, nothing. Everything was done by the residents. And if you talk to anybody who went through that experience, they loved it. The rules of engagement were simple. When we came on the ward service, fly in formation, no surprises on rounds, and patients always come first. Dr. Ottinger was our program director, and his philosophy, someone asked him, "What's the worst thing about being on call every other night, Dr. Ottinger?" And he said, "You miss half the good cases." We spent a year with Henry Wynn, and I was in the research lab with Craig Lillihai and Dan Doherty, and after about a month there, Henry put this up on the wall, which was not exactly politically correct, but we hence became known as the Three Stooges in his laboratory. But 1983 rolled around, and we had to think about, well, what am I going to do after general surgery? What are we going to do? And plastic surgery was exploding at the time. Craniofacial surgery was just 10 years of age. Tissue expansion, microsurgery, liposuction, myocutaneous flaps were on the knee. It's just been described. And so I decided to go into plastic surgeon, and Andy Warsaw, who was a general surgeon, said, "I'll buy you a book." And I said, "Well, I wanted you to buy me Matheson Nohai's book on myocutaneous flaps." He said, "Really?" But he signed it to me in memoriam to a good general surgeon who bailed out. So I started at the Mass General in plastic surgery, and there were people there that were very influential. James May, of course, John Constable, who was just mentioned. Jesse Jupiter was actually a hand surgeon, but we'd frequently work together on these massive replants that came into the MGH, doing a lot of hand and micro. And then there was Brad Cannon, the Cannon dinner tonight, and Gene Curtis. I went to Philadelphia in 1986 to do a fellowship with the idea that I would return to Boston the following year to start a craniofacial program, but soon discovered that in order to have a vibrant craniofacial program, you need a vibrant children's hospital. And I was fortunate to be exposed to Harvey Rose and Linton Whitaker during that fellowship year, and joined the faculty in Philadelphia. Had to tell Jim May I was not coming back, which was the same year that Charlie Thorne and John Siebert told Jim May they were going to train with Joe McCarthy in New York. So it was a tough year for Jim. But Jim, this is the early department, Peter Randall, Linton Whitaker, Ben Chang, David Lowe, Lou Bucky, and myself. And the reason I stayed was the Children's Hospital. The Children's Hospital was America's first children's hospital, established in 1855. It moved to Bainbridge Street, and then it moved to where its current site is, near the Penn campus. And when I started, we had one small room with one administrator, one nurse, 4 faculty, 2 exam rooms, 2 offices. But this was like heaven. This was a veritable smorgasbord of plastic surgery, facial palsy, craniofacial disorders, ear disorders, all of the things that I'd only read about in textbooks, but now could be mine. And I remember being let into that exclusive group of craniofacial surgeons by Joe McCarthy, who always the gentleman who sent me this photograph. And if you go look at this photograph, I was included. And you look at the left, Doug Osterhout, Harvey Rosen, Ken Salyer, Mike Uremchuk, Jeff Posnick, Tony Wolf, Fernando Ortiz Monasterio, Charlie Thorne, Barry Grayson, Hans Luhr, Craig Hobart, Milt Edgerton, myself, Daniel Marshak, Jeff Marsh, Bill Hoffman, Linton Whitaker, Paul Manson, John Persing, Joe Gruss, John Mullican, and then the front floor, Henry, of course, and Ray Broadbent, and then starting on Joe's side, Joe McCarthy, Joe Murray, and of course Tessier in the middle. To be included in that group was monumental. But the reason that I stayed was CHOP, and CHOP has now grown into a large institution of 900 beds, which we think is one of the most vibrant craniofacial programs in the world. There have been 4 or 5 now chiefs of plastic surgery at CHOP. I served in the middle. And right next door, we're next to Penn Medicine, led by Joe Cerletti and the team that he's assembled there. And it's one of those few places where you have a vibrant children's hospital and an outstanding medical adult hospital right next door. And the philosophy has always been that Linton, I was about 15 years younger than him. Jesse's about 15 years younger than me, and Jordan Swanson, who joined us, is a few younger than Jesse, has always continued the legacy. And part of that legacy is the fellows. I'm in the lower left when I was a fellow in 1985, but if you look on that fellowship list, there's Bob that you can see, there's Jack. You continued on, Steve Baker, Joe Losi, Devinder Singh. Many people are active in this organization. Mirko Gilardino at Montreal and so forth. The fellows have been instrumental, and we always get together and have a great time when we're ever at craniofacial meetings. And I have no idea what we were doing with those roses in our mouth, Bob. Do you? Do you remember that? And another one. And so there's a few organizations and activities I think have been important in my development. One of them is the American Alpine Workshop, which is the best group in the world. This was started by, and I was a member, asked to be a guest by Scott Speer in 1991. And I've been to most of the meetings, and everybody thinks, well, this is just a ski junket. But I can tell you this is the best meeting of the year. If you look at that group up there, it is where we have Phil Blondeel, who's here from representing EURAPS, and John, they're here, talk about breast reconstruction. Joe Losi talking about clefts. Fernando Molina talking about craniofacial surgery. Tim Martin, Jim Grotting, aesthetic surgery. Paul Saderna talking about hand surgery. Bill Kuzan talking about gender reassignment. This is by far, Steve Baker, Joe Cerletti, this is by far the best group I've ever worked with. And we get one day of the meeting, we close the door to all the guests, and we go behind and we talk about complications, because we all realize that complications are more instructive than triumphs. And there's a trophy given for that, and there's a fuzzy picture, and that's probably a good thing, because nobody can read the names of this. The other organizations that Bob mentioned is I got involved with Project Hope early on and started a liaison with the Polish American Children's Hospital in Krakow, where I've been a visitor for now 37 years, once or twice a year. And the value is this, is I was seeing craniofacial conditions untreated that we'd never see in this country, sent to me for referral, like this girl with Cruzons who's now 17, who's had only a craniectomy. And then if we started a foundation, we're able to give valuable, needed medical care to that part of the world. The other thing that has been important to me is the AO Foundation in CMF. Everybody knows about the AO Foundation, but it's really on musculoskeletal, including craniomaxillofacial. And all of the courses are multidisciplinary. There's a plastic surgeon, an oral and maxillofacial surgeon, an otolaryngologist in control. It's amazing how much you can learn during this cross-specialty fertilization, and both a hand-on practical as well as a didactic session. And this is from a recent trip in Lisbon just a couple of months ago, participating in an AO course. And they asked me to write the AO surgical reference on craniofacial disorders. And going through and creating an atlas gives you a new appreciation. It makes you think about everything over again and how you do it and different ways of doing it, and having the artist put it out on paper. The other organization that has been critical to my personal education is the International Society of Craniofacial Surgery. when I served as president in 2013. And that's given me contact to all the craniofacial surgeons in the world with an interest that is shared with me. And then finally, I don't know if anybody will recognize that picture on the right, but that is Rod Roerick in 1986, and in Monte Carlo with my wife. And Rod, as you know, took over the journal. We became fast friends and took over the journal. And he made me the section editor, the pediatric section editor. I served for 2 years. And that was very important because it made me read everything pediatric coming out for those 2 years. But the most important person, obviously, has been my family. My wife is a nurse, and she's a mother to my 2 children. And soon after we were married, this appeared on the refrigerator door. Fill out in triplicate. Each request will be carefully considered. We have 2 wonderful children, both successful. I don't think they have any drug problems. I don't think they have any tattoos. They're both gainfully employed. They're both very independent. And I have no illusion that that's due to me in any way, but it's only due to my wife. So I've been very fortunate. I've had a supportive family. I've had incredible mentors, incredibly talented mentees, lifelong friends, and supportive institutions, and it's really an honor. Thank you for this award.
Scott, thank you very much. I'd next like to introduce Linda Phillips, last year's president and current chair of the Honors Committee, to introduce the Honored and Distinguished Fellow Awards. Dr. Phillips.
Thank you. It's a great honor to be able to recognize people who are amazing. Just to get into the association is an honor. These people put in a lot of time trying to figure out which among the many deserving people would be recognized this year, and I thank the committee for all of their thought and effort about this. The Distinguished Award recognizes those who have a prestigious career, have considerable service to the association and other professional organizations of ours, recognizing those who lead in education or other areas of plastic surgery. A true leader and a giant in the area of microsurgery is Barish Strauss. Dr. Strauss is, I think, not here. No. But he is one of those people who really was the footsteps for many people to follow, and so we wanted to choose him. Next is our past president, Dr. Mackay, who has been outstanding as not just a president and many other contributions to the association, but also to many other organizations, past chair of the American Board of Plastic Surgery, past RRC chair, ACAPS, ASMS. I'm probably forgetting some, but he is truly a leader among leaders, and we wanted to recognize him. Dr. Mackay. Another past president who served also as chair of the American Board of Plastic Surgery, as well as the association, was particularly instrumental in a difficult time when we were having a turf battle over craniofacial surgery. And he helped weather the storm with his usual aplomb and diplomacy, and that is Dr. Kenna Given. Is Dr. Given here? No. Well, he truly got us through the rough time because he was so very gracious, and so we needed to recognize him. And then we have another amazing microsurgeon, innovative, great musician, actually rock band early on, who is one of those people who really exemplifies innovation and new frontiers in plastic surgery, Dr. Peter Nelligan. The honorary award is the highest award that the association gives, and it's recognizing outstanding contributions. It can be to the humanities or to science. It's not necessarily to a plastic surgeon. But this plastic surgeon has had a distinguished career and has given unfailingly to plastic surgery. Former Research Council chair, former at that time PSEF chair, vice chair of the Regents. She's represented us not only in plastic surgery, but across surgery, many years of a fairly thankless job as our representative on the FDA panel, past president, mentor to many of us, who was the original melter of the plastic ceiling, Dr. Mary McGrath.
Thank you very much. I very much appreciate this great honor. It's a real joy to celebrate my career, a career that's been marked by wonderful years in our specialty of plastic surgery with terrific patients, outstanding colleagues, and even sometimes really great institutions to work at. I wish you all the much happiness and success in plastic surgery as we go forward in the years to come. Thank you.
Thank you, Dr. McGrath, and thank you, Dr. Phillips. It's now my pleasure to introduce my colleague in Wisconsin, who's chair of the Research and Education Committee, Dr. Kent Lin. Kent.
Good evening. First, I'd like to thank Bob for allowing me the honor to serve the Society in this regard as the chairman of the Research and Education Committee. I believe that we are probably the second largest committee, and I do want to thank each and every one of the members of my committee. If you would please stand up to be recognized if you're here. All right, thank you. So, and before we go on, I do want to absolutely thank the people behind the scenes, in particular Shayla, who is the behind-the-scenes person in PRRI. Wonderful work with her in putting together enormous amounts of data and meeting multiple times to do what we had to do as a committee. So Sheila, I want to really thank you for everything that you've done on our behalf. So the charge of the committee is twofold. One is to do the Academic Scholars Award, and the other one is the Research Achievement Awards. And in many ways, it's very satisfying because the Academic Scholar Award is kind of like looking at the very beginning of somebody's career, and then the Research Award, or Research Achievement Award, is kind of looking at, you know, their sort of middle to end of their careers and what they've done. So it's kind of cool to watch the progression. And if you look in the back of your programs, you'll see the list of the previous academic scholars. And if you look at the names there, most of them have gone on to spectacular careers and are leaders in our field and in our society. So we must be doing something right in picking them out. So the Academic Scholar Award was established in 1992 to foster career development of an academic plastic surgeon and to facilitate the provision of sheltered research time and resources in the early stages of that individual's career. So this year we were fortunate to have two awards. The first one was the Peer Academic Scholar, and this has been awarded to Lisa Grafera for her study. You can read the name there. I'm not going to read the whole thing for you, but she was clearly a spectacular research proposal. So if you could come up. And the second award this year goes to Carrie Ann Mitchell, and this is the PSF Academic Scholar Award. Could you please come up, Dr. Mitchell? So just so that you should know, we had 8 outstanding applications, and it's just unfortunate that we couldn't give 8 awards for that. So that concludes the academic scholars part and on the program. I'm going to continue. So the Research Achievement Awards, again, there were basically 3 different categories: basic science and clinical research. And then we'll talk about the third one. The Research Award, Achievement Award was established in 2010 and recognized for people who are exemplary in outstanding research in plastic surgery. The candidates were identified by the Research and Education Committee. The names were put, finalists were put before the association, you all, to vote. And I'm pleased to be able to tell you the winners of those awards. So for the Clinical Research Award, and just so that you again understand, there were 14 different nominations for this particular award, and it was awarded to Bill Kuzan for his work in clinical research. Bill? So this is a good example of what I was talking to you about before. If you noticed, Bill was, I believe, the first award winner for the Academic Scholar Award way back when, so clearly it was a successful choice at that point. So the second award winner in basic science is Gail Cordillo. Again, we want to congratulate her for a career of outstanding research. So please come on up, Gail. So the last award is not always given. It's something that is recognized when the board decides that there is an outstanding candidate. And so it was decided this year that the Innovation Award winner is no other than your program chair, Frank Pepe at the Cleveland Clinic. So Frank, come on up. Now, thank you very much. That concludes the Research and Education Committee's work for this year.
Thank you, Dr. Lin. Outstanding choices. Next, it's my pleasure to introduce the President-elect of the American Association of Plastic Surgeons, Dr. Andrew Lee. Andy.
Thank you, Dr. Havlik, and good afternoon. Selected by the Awards Committee, the Leonard R. Rubin Award is presented each year to the author of the best scientific paper presented at the annual meeting. Dr. Rubin was the association's Clinician of the Year in 1986 for his facial paralysis work and was also an innovator for burn surgery during World War II. The recipient of the award will present the paper at the following year at the annual meeting of the European Association of Plastic Surgeons. We had a tough competition amongst all the outstanding papers presented at our centennial meeting last year, and I'm pleased to announce the 2022 recipient of the Leonard Rubin Award. Dr. Amy Cowell from the Mass General Hospital at Harvard Medical School for her paper titled A Decade of Nipple-Sparing Mastectomy and Immediate Implant-Based Breast Reconstruction, Lessons Learned. Dr. Cowell.
Thank you, Dr. Lee. Next, I'd like to invite Dr. Aaron Green back up. Dr. Green, who will be presenting the AAPS BCRF Young Clinician Award. Aaron.
I'm stepping in for Dr. Rohde. So on behalf of Dr. Rohde and last year's Scientific Programs Award Committee, I'd like to thank the committee for their efforts. The Body Contouring Research Foundation funds an award for the best paper given by a young plastic surgeon less than 45 years of age. And it alternates. One year it's given for the best clinical paper, and then the next year it's given for the best basic science paper. And last year's winner is Sashank Reddy from Johns Hopkins for his paper, Mechanical Stretch Mobilizes LGR6 Epidermal Stem Cells to Drive Skin Growth. It also comes with a $2,000 award as well. So Dr. Reddy, do you want to come up? Congratulations.
Next, it's my great pleasure to introduce the URAPS officers. I was lucky enough to attend the URAPS meeting in Naples, Italy last spring, and I was thoroughly impressed by the URAPS officers, by the URAPS organization, and by the quality of their papers. So it's my pleasure to introduce URAPS President, Professor Philip Bondil, and URAPS President-elect, Fabio Santinelli de Pompeo, and URAPS Secretary General, Professor John Franks. Gentlemen.
So, dear officers of the AAPS, dear Dr. Havlik, dear Bob, dear officers of the AAPS, and dear AAPS members. It's a great honor and pleasure as European AAPS member myself, but also and especially my second year as Secretary General of URAPS, to be part again of this excellent meeting with such an enormous tradition. Thank you so much for having us as URAPS officers on behalf of Philip, on behalf of Fabio Santinelli, and also Moshe Kohn, who is in the audience. At the San Diego meeting last year, presided by Dr. Phillips, I mentioned on the same stage as now the very rough climate Europe went through. And we intensely hoped then for the political waves to have calmed down by now. Unfortunately, they hardly did. We certainly all hope that a peaceful solution comes up soon, since one thing is clear. After COVID and the Ukraine war, it has become a totally different world with many new challenges, which strongly resonate also in our field of plastic surgery and in many different ways. So let our tight URAPS and APS bond across borders and cultures show the way by science, cooperations, and warm friendships. Last year, we indeed had a splendid URAPS meeting in Naples, including all rich Neapolitan flavors. We all, including many APS members, loved the Gatsby-style dinner in the stunning vintage train museum overlooking the Bay of Naples, and with all participants dressed up accordingly. Unforgettable pictures that bring a joyful smile on our faces still. And by the way of 300 abstracts submitted, 100 were accepted in 9 sessions. That's an acceptance rate of 30%. That makes the scientific program top 2. The beauty of Europe is exactly its cultural diversity in each country. The URAPS and URAPS Research Council meeting, starting May 25 in Stockholm, will be with Nordic flavors this time and promises to become unforgettable in a literally Nobel Prize setting. By the way, next year URAPS annual meeting will be in Athens, 2024, and 2025 will be in Palma de Mallorca, talking about exciting flavors. So we wish to extend our warm invitation on behalf of URAPS to all of you and welcome you also online at the 2 monthly URAPS webinars. And may I pass the word now to our current URAPS president, fellow countryman Philip Blondale, with whom I had the privilege, but especially the great joy to work together again for URAPS the past year with great enthusiasm, motivation, and ambition. Philip.
Bob, shall I need to introduce the best URAPS paper? Shall I go ahead and? Yeah. Okay. Good evening. Before I introduce the best paper at URAPS of last year, I would like to take the opportunity to thank Don and Linda and Bob for being great friends and colleague presidents of these sister associations. I learned a lot. I think we had a good collaboration over these years, and we continue to work together. And it feels very warm coming here. And I'm extending the invitation to come to our meeting next month or the next years. And I hope we can show as much hospitality in Europe as you do here for us Europeans being here. Thank you for that. It is my honor, like I said, to introduce the author and presenter of the best paper at Europe's last year, which is Gemma Pons. Gemma is a plastic surgeon, a vice chair and head of the microsurgery unit at the plastic surgery department of the Hospital de la Santa Cruz in São Paulo in Barcelona, Spain. She's associate professor at the Faculty of Medicine of the Universitat Autónoma de Barcelona, also in Spain, obviously. She is mainly interested in breast reconstruction, lymphedema surgery, genital surgery, and head and neck reconstruction. And a fun detail is that she was fellow in my department some X years ago. Gemma, please come to the floor for your presentation. Thank you.
Thank you very much for giving me the opportunity to present our preliminary results with a targeted lymphatic axillary repair to reduce the risk of lymphedema. As you know, lymphedema is a serious, chronic and irreversible disease that has a big impact in a patient's quality of life. And despite many conservative procedures are being performed with especially sentinel lymph node biopsy and also axillary reverse mapping, still the incidence of lymphedema can reach up of more than 30% after 2 years. And nowadays we are facing the escalation of axillary surgery because the community of oncologists and therapists are just trying to avoid the damage that we provoke with axillary lymph node dissection. And they are trying just to treat the axilla with neoadjuvant chemotherapy and radiotherapy. But despite of this, nowadays still a significant number of patients, they need axillary lymph node dissection. And besides, we believe that we can improve our surgical approach. And because of that, in 2017, we started with immediate lymphatic reconstruction with our concept of targeted lymphatic axillary repair. In this technique, we repair the lymphatic that we have just transected, performing supramicrosurgical lymphaticovenous anastomosis. We started surgery with using loop magnification and also microsurgical instruments. And the key is during the lymph node dissection to identify the afferent lymphatics that they are draining the arm. And besides, it's very important to preserve all the lymphatic structures that they are beyond the axillary clearance limits. Like you can see here in this picture, these linear lymphatic channels, they are just connecting the arm with the chest wall, and they are not going to the lymph nodes that we have to resect during the axillary lymph node dissection. Because of that, we have to preserve and not to damage them. And they are anatomically located above the axillary vein. Our technique is based in a reverse mapping with ICG, based in reverse mapping with ICG lymphography, where we inject the ICG in the interdigital spaces, and then we just draw the healthy lymphatic system of the patient on the cutaneous surface. And also, at the same time, at the lines that we have drawn, we inject the blue pattern dye that will help us just to identify and dissect the lymphatic vessels. We start with the standard axillary lymph node dissection levels 1 and 2, and then you just progress, like here, dissecting the innominate vein, and also below we can see the axillary vein. At this area, just at the superolateral aspect, is where we usually found the lymph nodes and the lymphatic vessels that they are draining the arm. In this case, we could find 3 or 4 lymphatic vessels that we just gently dissected, and we clip just where they are just meeting the lymph node. And also we navigate with the ICG just to confirm that they are the fluorescent ones, and they are the ones responsible of the arm drainage. Also, it's very important to dissect and to keep all the veins that we have during the dissection, and especially to dissect the smallest branches of these veins, that they are the ones that we are going to use for the anastomosis. Here, once we finish the resection of the lymph nodes, and in this case also we use the lateral thoracic vein, and we dissecting also until the smallest branches in order to have a good matching with the lymphatic vessels. Here we had the 4 lymphatic vessels ready for the anastomosis, and in this case we could perform 4 LVA, 3 end-to-end and 1 end-to-side with the innominate vein and also branches of the lateral thoracic vein. Here you can see how the patency and the vein is already absorbing the lymph that from the arm, and also we like to check with the ICG lymphography. In this patient of this case that she had to undergo mastectomy and immediate breast reconstruction with a scalp flap, we also perform lymph node dissection and TILAR technique. We just approach the same way with the reverse mapping with the ICG. This lady, she was very sportive and she had very strong and huge lymphatic vessels that were just rapidly reaching the axillary area. Also, as you can see, we inject the blue pattern at the lines that we have drawn, and in the once we open, we already could see slightly the lymph node containing the blue dye. Once we finish the lymph node clearance, here we could just preserve and some lymphatic vessels that were just corresponding to the line that we have drawn with the axillary reverse mapping. The veins are very important, as already pointed out. They have to have good valvular competency and they have to be near the lymphatic vessels. And in this case, we could perform 2 end-to-end and 1 end-to-side lymphaticovenous anastomosis. This is the result after the radiotherapy, 18 months after the surgery. And also the interesting thing is that all our patients, to assess our results, we perform ICG lymphography. And in these patients, 18 months after the surgery and also radiotherapy, she had all the lymphatic system completely preserved and reaching the axilla without any area of dermal backflow. We have just performed a prospective observational study of 35 patients from March 2017 to December 2020. The age at the surgery of the patient were 48, and the mean BMI, it was 25. Most of them, they had infiltrate ductal carcinoma. Also, more than 70% had received neoadjuvant chemotherapy, and more than 50% received autologous breast reconstruction. Related with the axillary lymph node dissection, we obtained a mean number of 14.69 lymph nodes, and more than 57% of patients had positive axillary lymph nodes. We had no postoperative hematoma or seroma in our serious cases. The TILAR surgery was feasible in 91% of the cases, and we performed a mean LVA of 2.1, and the mean surgery time was 170 minutes. More than 87% of the patients received postoperative radiotherapy, but in 51% of the cases that had negative axillary lymph nodes didn't receive direct radiotherapy in levels 1 and 2. All our patients, I already pointed out, receive, to assess the results, they undergo ICG lymphography 18 months after the surgery. And after a mean follow-up of 32.6 months, we had a rate of lymphedema of 5.7%, that is 2 cases. One of the cases had a clinical lymphedema, and the other one was just subclinical that we were able to detect with ICG lymphography, as you can see in the video, where there is a splash pattern of dermal backflow and just collateral lymphatics that are just trying to compensate the excess of fluid in the extremity. Related of these patients, both the two patients that had lymphedema had positive axillary lymph nodes. They received radiotherapy in all areas. One had a BMI more than 30, and in the other patient, we had no the possibility of perform TILAR technique. Interestingly, we published in 2021 this article where we just checked 504 patients that had undergone lymph node dissection from 2008 to 2018. And in our population, we saw that we treat in our hospital that we had a rate of 30% of clinical lymphedema. In contrast, when we offer the TILAR technique, we have achieved a reduction of this rate. Also, our rate of lymphedema is according to the ones that we can see in the literature, that is from 30.34% to 12.5%. Why we believe that this technique is promising? Just because compared to lymphedema patients, we are working with healthy lymphatics, with no histopathological damage, with good contractibility, and also with healthy veins. And with that, we have more chances for satisfactory results. But it's true that we also have some limitations in our technique. Sometimes we are not able to find the lymphatics. Sometimes the lymphatics are not reliable. Sometimes we cannot find veins, and also sometimes we have veins with no good valvular competence that they are not able for LVA. But even we believe that when we perform a meticulous and respectful in an anatomical point of view technique, we are able just to make a change of the results in these patients. Just to conclude, we believe that the TILAR approach based on our preliminary results is a safe, rational, and physiological technique. We have achieved a reduction of the lymphedema rate in our population, and also we can detect an early lymphedema and just give the patients an early tools just to avoid serious lymphedema that can impact the quality of life. Thank you very much. And just to finish,
Great paper. Thank you so much for your presentation. I'd like to welcome Dr. Arun Gosain back to the podium. Arun will be presenting the 2023 ACAPS Robert Goldwyn Mentor of the Year Award. Arun.
Thank you. So just a quick update. ACAPS is now ACAPS. We want to focus on our role as the American Council of Educators in Plastic Surgery, and nothing better exemplifies that than the Robert Goldwyn Mentor of the Year Award. For those of you who knew Bob Goldwyn, and certainly I was one of the fortunate people as well to know him, we established this award in his honor because he was such a tremendous mentor to so many plastic surgeons, and we want to recognize his mentoring and inspiration through this annual award. The recipient is an ACAPS member who's contributed significantly to the development of ethical, compassionate, and academically productive surgeons for the next generation. And our mentoring committee selects that to show the importance and the caliber of those who have gotten this award in the past. Can I have the prior Goldwyn Award recipients who are in the audience stand? And I know they're here because I've seen some. Thanks, Jim. Linda, Joe Losi, Joe Cerletti. So you can see the caliber of people we're trying to select, and they really have been true mentors to our group, and that's why we really consider ourselves the educators in plastic surgery. This year, I'm very proud to present this award to Amanda Gosman. As you all know, Amanda has been a pioneer in mentoring in so many areas internationally. You all know of the SHARE program that she's doing through the Plastic Surgery Foundation, which seeks to mentor international colleagues in plastic surgery. You know of the PREP program that she's doing in conjunction with ACAPS, which is seeking to mentor those from underprivileged and underrepresented minorities to enter plastic surgery, as well as all the work she's done in her local institution in hosting those with clefts from underprivileged and other countries. So Amanda?
Next is something new for the association. And I'd like to credit my two program chairs with this development. What they really wanted to do was to recognize the top 10 abstracts of 2023. This is really the creme de la creme of the papers over the past year. And all their idea, and I think they've done an outstanding job as they have with the program. So Dr. Jack Yu and Dr. Frank Papay.
Thank you, Dr. Havlik. So these are the top of the tops, the best of the best. We selected one top abstract from each category. And before I begin the announcement, I'd like to thank Olivia Ines. She helped us tremendously throughout the entire preparation, getting ready for this meeting. So we will read out the top 10, and please, for the moderators, identify these best of the best. The standard deviations were really tight, and the numbers are really low. So these are really good papers.
The first one is Aesthetic Breast Body Contouring. The title is Breast Implant Association Chronic Inflammatory Malignancies by Dr. Franco, Miranda, Rodriguez, Santiago de Pompeo, Hunt, and Clemens from MD Anderson.
For aesthetic phase is abstract number 5, Evolving Practice in Radicectomy, a 16-year review of continuous certification tracer data from the American Board of Plastic Surgery. The first author is Michael J. Stein. The senior author is Arun Gosain. The paper is from Laura Children's Hospital, Chicago, and the American Board of Plastic Surgery.
Next paper is on breast reconstruction. It's number 53 in your book. A look at the sequential return of breast sensation after autologous breast reconstruction. Is it worth the nerve graft? Primary author is Dr. Davis. Senior author is Dr. Soletti from University of Pennsylvania.
For basic science research, the best abstract is abstract number 20, Skin Barrier Dysfunction in Lymphedema. The first author is Dr. Adana Campbell from Memorial Sloan Kettering in New York. And the senior author is Dr. Babak Mehra.
The next one is Craniofacial Pediatrics, Achieving Facial Symmetry in 274 patients with hemifacial microsomia. Primary author, first author, Dr. John Reinisch, and senior author, Dr. Martin Vijverberger from University of Southern California and the Netherlands.
The next is from the category of education, practice, management, and other. The recipient is abstract number 50, Evidence-Based Medicine, Systemic Perioperative Antibiotic Prophylaxis, Prevention of Surgical Site Infection in Plastic and Reconstructive Surgery. First author is Kevin Clifton. Senior author is Devlev Elderman from University of Missouri, Columbia, and Johns Hopkins. I'm sorry if I didn't pronounce your name correctly.
Next subject is gender affirmation. The winner is perioperative estrogen hormonal therapy does not increase venous thromboembolism risk in facial feminization surgery. Primary author Alexander Lee, senior author Jordan Deschamps-Braley from Stanford and the Deschamps-Braley Clinic.
For For general reconstruction is abstract number 46, optimal computed tomography-based biomarkers for prediction of incisional hernia formation. First author is Ankur Talwar. Senior author is John Fisher from University of Pennsylvania.
The next paper is Hand and Extremity, a decade of vascularized lymph node transplant for the treatment of lymphedema, a meta-analysis of prospective clinical trials. Primary author, Dr. Tal Brown. Senior author, Dr. Joseph Dayan from the Sackler School of Medicine, Tel Aviv, and Memorial Sloan Kettering.
By the way, that last paper has the lowest score. That's the best one, score of 2.33 with standard deviations of 0.77, almost exactly 1/3 of the mean. The final one is outcomes, abstract number 58, comparing distal radius fracture outcomes in older adults after stratifying by chronologic age versus physiologic age, a secondary analysis of the wrist multicenter randomized trial. First author is Mayank Jararam, and the senior author is Kevin Chung from University of Michigan and MUSC. Thank you.
Again, many thanks to Dr. Pape and Dr. Yu. I think it's a really valuable addition to the program, the top 10 for the year. So thank you.